Adherence is not exclusively the responsibility of the patient, as it is an interplay between the various components of the treatment process: patients, medical doctors, pharmacists, other health professionals, healthcare systems, and the new technology available. In this video, we can learn a little more about new scientific advances in the use of technology in medication adherence.
Several definitions of adherence can be found in the literature, although the most widely accepted definition is the one suggested by the World Health Organization, in which adherence is the extent to which a person's behavior, taking medication, following a diet, and/or executing lifestyle change, corresponds with agreed recommendations from a provider. Currently, the term adherence is more valued compared to the word term compliance, thus referring to the idea of active and voluntary involvement of the patient, achieve better results in the patient's health condition. For the treatments to be effective and there is a correct efficient disease management and prevention, is necessary a correct adherence to the therapeutic plans by the patient. As it said Charles Everett Koop, drugs don't work in patients who don't take them. The process by which patients take their medications can be divided in three main phases. The first phase, initiation. The patient may or may not initiate the treatment. That is, he makes a decision, yes or no. If the patient decides to not start the treatment, it is classified as primary non-adherent. If the patient starts the treatment, we are in the second phase, implementation. Here, non-adherence is assessed by dosing history, such as patient delays or meets or takes extra doses. In the last phase is called by persistence regarding the time of the event. Thus, this is the time when the patient discontinued treatment earlier than prescribed. In the different phases of adherence process, there are different levels of non-adherence. 25% of patients do not initiate a new prescription. This prevalence grade is dependent of the disease, drug types, centers, and healthcare systems. Daily, 50% of patients do not implement as prescribed, being related with food requirements and the complexity of treatment. During the first years, 40% of patients have discontinued treatment, and causes are similar to the ones associated with the first phase. As you can see from this chart, about 20% of patients don't start treatment, and about 40% is classified as non-adherent during the second year of treatment. Therefore, at the end of 1 year of treatment, adherence levels are only 50%, reaching 40% after 2 years. Once given an overview of adherence to treatment, how can we assess adherence? There are two generic ways to assess adherence. Direct methods, such as a directly observed therapy, measure of the levels of medicine or metabolite on blood, or measure of biologic marker. And indirected methods, such as a patient questionnaires, self-reports, patient diaries, pharmacy refill data, electronic medication monitors, or assessment of patient response. Overall, we can classify adherence levels into three categories: high adherence, equal to or greater than 8%; medium adherence, between 40 and 8%; low adherence, equal to or less than 40%. However, the adherence level classification must be made in the context of the drugs. In the literature, many factors related to non-adherence to therapeutic plans are described. According to World Health Organization, these factors can be grouped into 5 domains: socioeconomic factors, such as the cost of treatment and social support; health system related, associated with patient and prescriber interaction; therapy related, such as a drug regimen, drug handling, drug packaging or formulation, adverse drug reaction, and drug-drug reactions; patient related, such as a mental state, physical health, demographics, knowledge, and behavior or habits; and condition-related, associated with the characteristics of the disease.